Dear colleagues, ladies and gentlemen, welcome to this PCR webinar on optimizing TAVI procedural outcomes in challenging anatomies. My name is Nicolas Vermighem from the Erasmus University Medical Center in Rotterdam, the Netherlands, and I'm joined today by Darren Milot from Galway, who is an interventional cardiologist, and Mauricio Taramasso from Zurich, who is a cardiac surgeon. So to go in a little bit further on our objectives of today, I'll give the floor to Darren. Darren.
Thanks, Nicholas. So welcome everybody to this PCR webinar. Today we're going to discuss vascular access and how we can potentially mitigate vascular complications. Nico's going to show us a case with some interesting new techniques that you might want to use in your cath lab. We're going to talk about reducing paravalvular leak. How do we do that using specific valves, using specific techniques? And then finally, how do we address more complex procedures? For this 60-minute webinar, Nicholas and Mauricio are here to answer your questions. So please don't hesitate, no matter what your question is, send it in to us and I'll make sure that they answer it for you. So Nico, let's get started with a case because I think that's how we all learn best.
Yeah, so the first case was a case that we did in Rotterdam a couple of weeks ago, a 70-year-old female obese patient who also has systemic lupus for which she received chronic immunosuppressants. She has a low STS score, but because of the obesity and the corticosteroid dependency, she was deemed a good candidate for a TAVI procedure. And so she was a New York Heart Class 2. And basically, this is her echo. You can see a preserved LV function, severe aortic stenosis with a maximum velocity of 5 meters per second, normal coronaries, no significant coronary artery disease. And then, as always, we do pre-procedural planning by CT scanning. This is very important. We identified a tricuspid but functionally bicuspid valve with heavily calcium, clearly appreciable here. Especially at the transition of the non-coronary and the right coronary cusp. And then what we do is we scroll through the anatomy to get a clear understanding what we can expect. You can see the hypertrophic ventricle. And then we also focus on our peripherals. So the femoral axis is quite nice from a TAVI point of view. And in Rotterdam, we also use cerebral embolic protection, filter-based protection. And for that, we typically analyze the brachiocephalic trunk to make sure that we are able to insert our devices. So with that, I think this is the first video of the case. I think in terms of patient selection, Darren, we may ask Mauricio from a surgical perspective, is this a surgical candidate or would he feel comfortable with TAVI?
Thanks for the question. Well, as you said, obviously, looking at the number, this is a potential surgical candidate. Of course, I would say this is for sure not a low-risk patient, independently from the STS for two reasons. One, the one that you mentioned, chronic immunosuppressive therapy and corticosteroid therapy, that we know that they make the tissue quality much more frail than usual. So obviously, this is something that we have to consider. And then also obesity. I think there are more and more data showing that the hemodynamic of TAVI valve are slightly in favor of less patient-prosthesis mismatch, especially in obese patients. And then even if you can perform surgery with a minimally invasive approach, I think to operate on an obese patient is not something that is easy or straightforward. So I think this is a really nice indication in terms of clinical profile and also in terms of anatomical profile, let's say.
So that seems... Sorry, Nico, go ahead.
Yeah, there was already a question from one of the participants who is already upfront asking about post-procedural care. So we know that we have our patient here. Is this a patient that you would consider for specific attention in the ICU setting? Or is this some patient that you may want to even discharge or get back to a general ward? How would that go in Galway?
Yeah, it's a good question. Clearly a young patient, but she certainly has some indices of frailty. I think the first thing that we'd want to do is make sure that we had good antibiotic prophylaxis, make sure that she had no evidence of infection coming in for her procedure. So we would normally admit most patients on the morning of their TAVI, but we might bring her in the night before just to ensure that she had no temperature, her CRP and white cell count and so forth are okay.
Mm-hmm.
Equally, if her procedure goes well, I wouldn't find any other reason that you'd send her to an ICU or to a high dependency ward, where very often patients end up with more rather than less invasive monitoring and so forth. So I would avoid urinary catheterization. I would try and minimize the number of access points that we're going to use for the case. Let me ask you something, Nicholas. I think that Mauricio touched very nicely on a patient who's potentially at risk for patient prosthesis mismatch because she's obese. What were you considering in terms of valve choice, given the heavily calcified valve that we see here, and the importance of good hemodynamics for this young lady who's going to have a long life expectancy?
Yeah, I think this is very important. Younger patient, longer life expectancy. So we want to avoid patient prosthesis mismatch as much as possible. I think for some cases, we would not do a pre-dilatation. I think with this kind of calcium, you pre-dilate for all the valve platforms that you would like to consider. But then again, you also would want a valve platform that is known to have good hemodynamic valve performance, low gradients, large valve areas after the valve implant. And with that, I think we have several options these days. You have this typically supraannular functioning valves, but also the Navitor system is clearly known with good hemodynamics and a very good hemodynamic valve performance after implant, with valve areas above 2 centimeters square in a wide range of anatomies and sizes. So those would be my major considerations in the beginning.
Mauricio, if I can ask you, again, in terms of that lifetime management, this lady doesn't have coronary disease now. Would you prefer a system here where you're beneath the coronary arteries, above the coronary arteries? Obviously, the difference from platform to platform can vary in terms of coronary access. How would you explain that trade-off to the patient?
Yeah, it's another really good point, because the longer is the life expectancy, the more is the time that the patient has to develop coronary artery disease. So even if now the coronary artery are normal, we know that the prevalence of coronary artery disease in patients with aortic stenosis is really high. So this is a patient where we should think in the follow-up that it may be necessary to do something in the coronary. So we should try to preserve as better as possible the coronary access. And in this regard, obviously, you put all together, you want to avoid patient prosthesis mismatch, you want to have good hemodynamic, less paravalvular leak, less pacemaker rate, but you want also to preserve coronary access. So I think in this case, Navitor valve is a really good, let's say, compromise between good hemodynamic, intraannular leaflet, so intraannular valve. So this should make access to the coronary easier, larger cell in the stent, and also the possibility to do commissural alignment, even if we may discuss later on is not always achievable or, let's say, straightforward to be sure, but for sure you can do it. And putting all together all these aspects, I think it is a really well-tailored approach for this specific patient.
Yeah, and maybe one other thing that we haven't considered very often in the past is the ability to revalve whatever index TAVI device that you put in. Yeah. If you have annular leaflets, if you have access to the coronaries through the longer stent frame, or indeed if you take a shorter balloon expandable valve, they're all important factors when we consider maybe revalving this patient in, 10, 12, 14 years' time. Nico, before you go on and show us what you did, one thing I liked that you mentioned was the presence of the left ventricular hypertrophy on the CT scan. Mm-hmm. That's something I think that people often don't take advantage of when looking at the CT, and it's something that we routinely do and for us, that would help us choose, for example, the type of wire, be it a Lundquist, a Safari, a small Safari, or extra small. What do you use that for? How does that impact your case?
Yeah. Yeah, well, in very thick ventricles, especially if there are kissing ventricles, that would really lean me to the extra small safari wire. So then I don't think you should need a large bend in your shaped wire, because that will only enhance the risks for pop-outs. So then I would prefer a wire with a very simple and small shape at the end of the wire. At the same time, and this is also addressing one of the questions of the audience, are you considering then specific fluid protocols after the valve implant? Because you obviously you want to avoid a suicide ventricle, you want to avoid a hemodynamic compromise because of the hypertrophic state, and maybe in a patient that is hypovolemic. This is definitely something to take into account, so volume management. But we'll get to that in the case. I think it's mandatory, especially in these patients, but maybe in a broader way in all the patients, to have a good hemodynamic assessment before and after the valve implant, just in order to manage the hemodynamic state of the patient. But with that, maybe we can continue with the case. So as we've shown the pre-procedural planning by CT, this is our access. And what you see is we have a right radial access, and then we have a right femoral access with a common femoral and a suprafemoral artery access. So we use one femoral side. We don't want to use the two femoral sides, so only a right femoral access with a 6 French sheath in the superficial artery that will accommodate the pigtail, and a 14 French sheath in the common femoral. On the left side, we just pierce the skin with a needle that will help us for LV pacing when we do balloon dilatation during this procedure. So that is basically our simplified, minimalistic, if you will, access approach. So we have a radial access for cerebral embolic protection, filter-based protection, and then we have a single access right femoral, superficial, and common femoral artery. Is this something that you would also consider in Galway?
Yeah, it's an interesting approach. I haven't seen it very often before. We would have our secondary access via the left radial artery and enjoy that, I suppose. But maybe you might tell us what do you think are the advantages, Nicholas, of that single common femoral and superficial femoral access compared to a left radial approach, for example?
Yeah, so obviously we are already using a right radial. So if you would use both radials, that will invalidate the patient more or less in the first couple of hours after the procedure. Same thing holds if you would rely on a double femoral approach, left and right. That will affect ambulation of the patient. So that is the argument, the rationale to go with a single access side. So right femoral, a common femoral, and superficial femoral artery. There is, and so it adds speed to the procedure. So the procedure flow is very fast. And at the end of the procedure, after we took care of our large bore access, it's very easy to confirm successful closure or patent hemostasis, if you will, by using that 6 French access sheet that we still have in the superficial after closing the large bore access of the common femoral artery. So it's ease of use. It's also to improve ambulation and maybe improve patient satisfaction after the procedure. The only downside that I see is that if there is no hemostasis after the retrieval of the 6 French sheath, where we use a Perclose Pro style, if that would be unsuccessful, then, you know, compression might be a little bit more cumbersome because you are below the level of the femoral head. So it's very difficult to compress that artery completely in that particular case. In our planning, we typically do an additional analysis of the femorals. We want to be sure that the iliacs and the femoral artery can accommodate a 6 French or a 5 French sheath for the pigtail, and then a large bore catheter for the valve delivery. So that is something that you need to take into account when you do your pre-procedural planning by CT. Look at the size of the iliacs, but also the distribution and the amount of calcium. Because if there's circular calcium for a long trajectory, especially if the size is less than 6.5 millimeters, then it can become tricky.
Yeah, it's an interesting approach. Maurizio, what do you think? Is this something that you would try in your hospital? I think it certainly is something we'd have a go at. That I think the disadvantage of the left radial is that after the procedure, you then have to recross down into the descending aorta, take a long catheter down to do your check angiogram. We've got around that by starting to use ultrasound rather than a final injection in the large bore access. What are your thoughts?
I think it's a nice approach. We have been doing a lot of cases with this single, so same side access approach. And I think the most important, there are a lot of advantages, some drawback that Nico already mentioned. And I think the most important message is that you have to select the patient. So you have to look at the CT, which are the good candidates for this approach, which is the vast majority, obviously. But there are also some candidates where you may have calcific, smaller vessel, where you may expect, for example, difficulties in steering the pigtail if the pigtail lose the position. So that could be more difficult to repositioning. Or patient where you may think to have a high risk for bleeding. So I think the most important is that probably there is not a better approach or a best approach than the other one. I think selecting the patient and taking in consideration during the planning which are the good anatomy for these approaches is the most important. And as Nicola said, I see a lot of advantage in this approach. So I like it, but honestly, this is not our standard. We do different. So we 3 center, we do 3 different. We use the contralateral femoral as diagnostic access, just because I mean, if we need to intervene at the end, we find this with a femoral crossover easier. Also from the material standpoint, you don't need specific material, longer balloon, and so our standard is to use contralateral access. But again, we select the patient during the planning, and we try to find the best approach for each anatomy.
Perfect. So, Nico, let's move forward with the case. You said you were using embolic protection for this patient. Is that your routine for most patients? And maybe you might take us through the steps involved in deploying the Sentinel device.
Yeah. So let's go back to the slides. And this is here where we deploy the filters. So it's very easy. We use an LAO 30 projection that opens up the bifurcation, if you will, of the aortic arch and the origin of the brachiocephalic trunk. Then there was that pigtail that marks the outer curve of the arch. And then you deploy the first filter in the brachiocephalic trunk, and then you can manipulate the handle in a way that you create a curve at the end of the catheter. And then it becomes very easy because you know by CT scan where the origin of the right common carotid will be. And then you can briefly adjust the angulation of that catheter. And then with a coronary wire, you probe and then eventually enter the common carotid. Obviously, this needs to be an atraumatic experience. You don't want to create a lot of damage by inserting the filters. And this will be one of the major points of interest also from the protected TAVI trial that will be presented next week at TCT. You want to know, can you use these devices without any major complications? So if they add complications and add complexity to the procedure, then we may want to think twice. I think from a planning point of view, based on a CT scan, we would exclude 20 to 25% of the patients just because we would anticipate a difficult deployment of those filters. What you then see here is a hemodynamic assessment. So after crossing the valve, we insist on measuring the transvalvular gradient and also the left ventricular end diastolic pressure. We determine the aortic regurgitation index, The LVDP is important to understand the filling status of the patient and to maybe also determine the kind of attention that the patient would need in terms of fluid therapy after the procedure. It also is important to help determine the AR index. The AR index will help us understand the severity of paravalvular leaks if they would be present after the valve implant. And you want to have your reference. This is where you make the time when you make your reference. An AR index upfront before the valve goes in is required to help understand the AR index after the valve implant. So this is also addressing one of the questions of one of the participants. So should we use cerebral embolic protection in all patients? Yes or no? And are there anatomical restraints? So yes, there are. And I think if you use filter-based embolic protection, there are some limitations anatomically. And I think grossly 1 in 4 of the patients would not be eligible for a sentinel filter embolic protection.
Nicholas, you told us that some of those patients you would exclude. What are the types of patients you would exclude first? And second, when you're trying to deploy a filter and you're having some difficulty, for example, if it goes to the descending aorta rather than the ascending aorta, or if you just can't get, for example, the filter up into the carotid, how long would you spend trying to execute that before deciding that maybe this isn't in the best interest of the patient and abort the filter experiment?
Yeah, obviously. So we have been doing these filter-based embolic protections for the last 10 years. So we have built quite some experience, but still for me, there is a hard stop at 5 minutes. I don't go beyond 5 minutes of attempting to get my filters in place. Typically, it requires 60 seconds, so it's very fast. But if I would need advanced maneuvering, then I give myself a maximum of 5 minutes. Basically, we're also getting better and better in understanding when to anticipate issues, and when there is excessive tortuosity in the right subclavian artery, or when there is advanced atherosclerotic disease at the landing zones of the filters, those are situations that you want to avoid for filter-based embolic protection. Obviously, there is an entire industry related to cerebral embolic protection. You have filter-based, but you also have deflectors that might be protective. We'll have to see how this field will develop, and I think again the protected TAVR study will be an important point in history of cerebral embolic protection, whether or not that is going to be a positive study for the need of embolic protection. But I am a strong believer. Basically, when you look at the content within the filters by microscopy, you will find debris in all the patients. So, and in 50% of the patients, that debris will be macroscopically visible. So I think, for me, I'm sometimes even wondering, do we need a randomized controlled trial? Because who is doubting the concept of capturing debris in every TAVI that we're doing?
Yeah, it's a good question, and obviously protected TAVR on Saturday or Sunday at TCT is gonna give us the first piece of that question. Of course, we have the British Heart Foundation funded Protect TAVR study that is coming, which is more than twice the size of the Protected TAVR study. That's about 1/3 the way through enrollment. So even if Protected TAVR gives us ambiguous signals, there's another 7,000 patients coming in due course that certainly will clarify for us the role of filter-based technology, or this particular filter-based technology in embolic protection. Nicholas, let's get forward with the case. We saw the hemodynamics, and I think Maurizio and I would agree that assessment is important to understand what you have before and trying to match it afterwards. You selected the Navitor valve for this patient, given the annulus size, I presume a 27 millimeter Navitor. And maybe you might talk us through how you implant that device.
Okay, that was the hemodynamics. We saw that. Okay, so then we have the stiff wire, and over that, so we did a pre-dilatation, and after the pre-dil, we insert the Navitor valve, and here we are pointing to the way the orientation of the delivery catheter with that flushing port that needs to point to 3 o'clock in order to have the higher likelihood of commissural alignment, and this is for lifetime management, obviously very important. The tracking of the system is, I think, maybe the best in class. It's a very flexible delivery catheter that easy maneuvers through even tortuous anatomies. And then the deployment is very straightforward. I typically start in a coplanar view, and you have that marker that is on top of the annulus, and then it's a very slow deployment. There is quite a good transmission of the rotation that we're doing on the handle. And then in principle, this is an extra small safari wire. You see how stable the valve system is in this particular case. And then you have a hard stop at 80% of the deployment. This is where we would cross over to a cusp overlap view, as we're doing here, to confirm the implant depth. And once we're happy, we take it back to a coplanar view and then slowly release the valve.
So let me ask you a couple of questions then about the deployment. So you mentioned the valve is very soft, very subtle, coming around the arch, which is important. And then what is your intended depth of implant, and what view do you start with or change to during the case? Take us through your strategy.
Yeah, so I use an integrated approach relying on a conventional coplanar view with the 3 cusps aligned, and then a cusp overlap view where you have the overlap of the right and the left non-coronary cusp. Why I use the integrated approach? Because I want to try to monitor commissural alignment, but at the same time also I want to have a good appreciation of the implant depth. And for that appreciation, you need 2 views. You cannot rely on 1 view. And basically that is the reason why we use cusp overlap and coplanar in the same patient.
Okay, I think that's a good approach. I don't think anyone could argue that having more information is in any way deleterious in trying to ensure that the patient gets the best outcome. So we would do the opposite. We would use an REO caudal or a cusp overlap view to start and assess the implant depth. And then we would roll towards the LAO to make sure that we're underneath the left coronary cusp. But 2 views, I think, is perfect. You also mentioned that you're releasing the valve very slowly. Is there any need for pacing during the procedure, be it during the initial deployment or to keep the valve stable, or when you're releasing the valve at the final phase?
That's a case-by-case decision, I must say. If the early deployment goes very steady, then I will not use pacing. If you see that there is a lot of ectopy involved, that might be a reason to do LV pacing. But in principle, the majority of the cases will be without pacing when I would implant self-expanding valves.
Perfect. So maybe take us through how the case finished, Nico. We saw a nice stable implant. What were the hemodynamics afterwards? And in terms of reducing the risk of PVL, how did you do with this heavily calcified valve using the Navitor system?
So here the valve is in, and then you can see by aortogram there is no PVL. At the same time, then it's the moment to retrieve our embolic protection device. That was the valve deployment. Yeah, this is already the aortogram, but you have to believe me that we did do a hemodynamic assessment at the end of the procedure before we made the aortogram. We don't do an echo anymore, so we rely on AR index and aortography to determine the paravalvular leak. Here we're already closing the groin. In the interest of time, I think makes sense to already focus on this. So we used a pre-closure with 2 ProGlides. And again, I think most of us will be familiar with then closing the sutures. But at the end of the 2 sutures, when we see that there is a residual ooze, we make the decision whether or not to proceed with an angioseal, and this is what we're doing here. And here I inserted the sheet of the angioseal, and I can see that the oozing has stopped. So that makes me give up the wire and then deploy the plug of the angioseal, because now I'm sure that I will have hemostasis after the deployment of that angioseal. If I would have residual oozing next to the sheath of the angioseal, then I might have opted for an additional suture. So, and then here is the magic of that single access site. It becomes very easy to assess because I have a catheter right beneath to confirm that I have a nice closure. And then at the end of the procedure, I take out the 6 French sheath and use another suture to close my superficial femoral arterial access.
So that looked great. We didn't see any paravalvular leak, which is, you know, exceptional in a heavily calcified case like that, and very important for this young female. I very much like the addition of the extra PER close, the extra plug-based device on top of the PER closes. One thing that we struggle with or struggled with were the calls from the general ward that the patient has had some oozing or patient has had a hematoma, and that has gone away since we started using that technique of either a single PER close and an angioseal, or as you did, 2 PER closes and an angioseal. And I very much like the expediency of the quick angiogram via the superficial femoral. So congratulations on a great case and a great outcome for that young lady. Mauricio, I think time to move forward, and maybe you might take us through your case, and maybe just to reiterate to all the people online, please come forward with your questions. Nico, have we any questions that we haven't answered yet from your case? Maybe this is the moment before Mauricio takes us through his case.
Yeah, so one of the questions relates to RV pacing or LV pacing, as you also did. Would that reduce the incidence of valve misplacement? So basically, would you have a more stable valve implant by systematically doing pacing during these valve deployments? What is your practice, Darren?
Yeah, it's a good question. So I would say that we use pacing on the wire for all self-expanding valves. And we use a temporary RV pacer for all balloon expandable valves. And our experience with balloon expandable valves is less, and that's why we are probably more comfortable with the temporary wire in situ. In the vast majority of cases, we get very nice pacing on the wire using wire-based pacing. So that would be my strategy for the vast majority of cases. I have had cases where I've lost capture, be it with the balloon expandable valve or with a self-expandable valve, and that has caused trouble for me when using pacing on the wire. But equally, you can sometimes lose capture when you're using an RV pacer too. The pacer can move. So I certainly like pacing on the wire. I find it quicker. Sometimes the longest part of the procedure is getting that pacer into the RV. So yeah, that's my experience. But interested to hear your thoughts, Mauricio. What do you do?
Yeah, we do exactly the same. Actually, we do it also for balloon expandable valve. The only cases where we put pacemaker wire through the jugular are the cases who are already started with high risk for conductancy disturbances. For example, heavily calcify LVOT in the region of the membranous septum, or really short membranous septum, or pre-existing AV block, or right bundle block, branch block, obviously. Otherwise, we use pacing over the wire in all cases. And so far, we never had trouble. You just need to be ready. The team need to be ready, the team in the room, in the rare case you have acute asystole. So when you do stop pacing, you should not go to zero. You should maybe train the one who is handling the pacemaker to progressively go down, because sometimes it may happen that you have asystole. Or if you have a severe paravalvular leak and you may need to do rapid pacing to sustain the hemodynamic, this is also something that you should be ready to handle. But otherwise, I mean, if everybody's on the same line, everybody's used to this approach, I think it's an important step forward, also because I think everybody has some experience of hematoma in the neck or also in the groin due to the venous puncture. So if we can avoid it, I think it's better for the patient for early mobilization and so on.
Super. Mauricio, take us through your case. Let's hear about the case that you treated recently in Zurich.
Yeah. So this case will focus mainly on access management and then on some aspect of the implant. So it will be a bit of a repetition maybe. I think my slide control is not working, so you may maybe advance for me the slide. Okay. Here you see the profile. It's a typical, another patient that we would define low risk, a 74-year-old man. In this case, there is a previous coronary artery disease, which has been already stented few months before the procedure. The patient get stenting on the LAD. As a risk factor, the patient had radiotherapy due to lymphoma several years ago. So this is something that obviously speaks in favor of TAVI. The patient came to our attention with a severe tricuspid degenerative aortic stenosis and also associated moderate to severe aortic regurgitation with a preserved ejection fraction and moderate pulmonary hypertension. And looking at the STS score, you see that this would qualify for a low risk profile. Next slide. Just quickly going through the CT planning of the patient, I would say here you see the annulus. It is a rather elliptic annulus with a perimeter of 75, not really calcific. Actually, the LVOT is also quite elliptic, larger than the annulus, but nothing really, I would say, challenging from an anatomical standpoint. Next slide. You see here the tricuspid configuration of the valve with calcific leaflet, not as heavily calcific as the case that Nico showed us before. And you also see the STJ here, which is not calcific as well. So I would say a really nice anatomy for TAVI. Next slide, and I think this has to be considered when we weigh the decision surgery against TAVI in a low-risk patient. We want to treat low-risk patient with really nice anatomy for TAVI, I think. Here you see the coronary high, which were favorable. You may see calcification in the proximal LAD and the mid portion of the LAD where the patient got already a stent. Next slide. From access side, no particular issue. The access were both pretty much big, no tortuosity. As I told you already before, our standard is to use the right femoral, common femoral artery for the valve, and then the contralateral femoral for the diagnostic access. And then we usually use on a routine base also cerebral protection device. So our third access is the radial access for the Sentinel device. Next slide. And this is the plan for this case. So implantation of a Navitor 27 through right femoral access. We do predilatation in basically all cases of aortic stenosis, even if the calcification pattern is not severe. We obviously perform the cases in conscious sedation, and we perform closure with 2 prostyle, and then we pace over the wire and we use cerebral protection device. I don't know if you have any comment on patient indication or planning.
Yeah, so I think let's discuss the case for a few moments. Nicholas, is this in your center a standard TAVI case? Is it the pulmonary hypertension, or is it the previous wide beam radiotherapy that swings it towards TAVI in Rotterdam?
Yeah, I think both. I think obviously a 74-year-old patient needs to be discussed in the multidisciplinary heart team. I think basically all the patients who would require a bioprosthesis should be discussed in that particular team. And our surgeons would be very open for the idea of TAVI in this patient. I'm not sure whether I would call this patient low risk. I think there is quite a significant medical history here, and the radiation, I believe, makes recovery after open heart surgery potentially a little bit more cumbersome. So I would feel, I agree with the selection strategy here.
Can I ask you both, in your institutions, do you have a specific age in mind whereby all things being equal, the patient would go towards surgery or the patient would go towards TAVI? Maybe Mauricio, as a surgeon, you might tell us first, and then Nico from Rotterdam. Of course, case-by-case selection, but is there a ballpark where you change?
I think we rely mostly on the last guideline. So 75 is, let's say, our root cutoff, but then obviously it's case-by-case discussion, as you said. But if you ask me, a cutoff is 75.
Yeah, the magic number is 80 in the Netherlands, and that is because that is the cutoff for higher operative risk in the Netherlands. Okay,
so again, regional differences, despite I suppose divergent guidelines from the US and from the EU. Yeah, we're about 75. Again, similar to Mauricio, if all things are equal, above 75 goes to TAVI and undergoes to surgery. I must say we have had some really nasty bicuspids recently in 75, 76, 77-year-olds with long calcified raphe, patients who were in good condition. And we simply transferred them over to surgery because we felt, well, they'll probably get a better outcome for surgery. So I think a collegial approach is important. I would agree that all patients should continue to be discussed. I like the idea of that forum. Mauricio, one thing again that came up was the pulmonary hypertension. That's one of the things that scares me a little bit in TAVI. You know, if you have patients with severe pulmonary hypertension, they're the ones that halfway through the procedure become quite hypoxic on the table and drop their blood pressure and can get quite sick. Do you have any specific guidance for us in terms of how to approach TAVI in patients with elevated pulmonary pressures?
Actually, in this specific case, was not a severe pulmonary hypertension, was around 40, 45, so something quite common. But in case of severe pulmonary hypertension, actually, what we tend to do, we tend not to intubate the patient. Obviously, if the patient can stay, let's say, can maintain for 45 minutes the supine position, and then we transfer them in the intermediate care, and we just keep an eye on them, and we are quite, let's say, liberal in keep them for over the night there rather than transfer them immediately to the ward like a regular case. But regarding the, let's say, procedure, we don't do anything different than a normal case. We just stay on our standard protocol. I don't know if you have any differences in this patient, but actually we don't do anything particularly different from a procedural standpoint.
Yeah, I suppose, again, only in patients with severe pulmonary hypertension, we would let our anaesthetist know. We don't have anaesthetists with us routinely during cases, but if we do have a patient with significantly elevated pulmonary pressures, we would just let our anaesthetist know that morning that at 10 o'clock, 11 o'clock, whatever, we would be doing that case because we might sometimes need some help. Nicholas, any questions from the audience?
Okay. Sorry.
Yeah, so the audience has quite some questions on the pacing, but I assume that we will get there in a second during Mauricio's case. So maybe we can continue with the case for the time being.
Perfect. Let's go, Mauricio.
Yeah, we can move to the first part, the next slide, which is the first part, access preparation.
Our standard of practice is to perform the puncture of the femoral access with ultrasound support. So we thought, and I think this should be standard of practice, that the visualization of the bifurcation of the correct spot for puncturing is safer with the ultrasound use. Now you see the short axis of the artery. Obviously now we will check also in long axis where the bifurcation is. We may even see the femoral head here below. You see this kind of curve echo structure is the margin of the femoral head, so actually we can really know where we are with ultrasound. This is the bifurcation in the short axis, and we will go slightly more cranial than the bifurcation, ideally in the mid of the femoral head. This is obviously the diagnostic puncture, so it is less crucial to be perfect, but obviously if for any reason we have to switch to this axis, or if you have any problem, we want to be perfect as well. Now you see the introduction of the needle. Obviously, with ultrasound, you can see exactly the point where the needle is. You see now the tip of the needle pushing on the artery exactly in the middle. It is a spot free from calcification. And now we can introduce the wire. Okay, now we are ready to puncture the contralateral axis. You see here really well the bifurcation you have seen in short axis. This is above the bifurcation. You can see also the femoral head quickly, you have seen. This is the long axis. There is a calcification on the posterior wall of the artery. So we will try to puncture not where this calcification, even if it is in the posterior wall, so it's not gonna create any major issue, because we will deploy the prostyle obviously in the ventral part of the artery. Here it seems to be a good spot. Yeah. You see the artery, you see the vein on the medial side. Now we introduce the wire, and that's it. Now, by doing like this, we are sure that we are in a calcium-free spot. We are above the bifurcation, and this is, I think, the best puncture that we can offer to the patient. Now, as a next step, we just prepare the artery a bit with a 6 French sheath. It's really important to do a small little incision on the skin of the patient to make the introduction of the further sheath and also the prostyle smoother. Just less than 1 millimeter is enough, just to assist in the IFU, 6 French 4 oder? Ja. Okay. Nein. Die Device selber hat 6 French. Aber okay. And now we are ready to perform the preclosure. And now the proglide is inserted in the artery. It's really hydrophilic. You can really feel that it goes smoothly. As for the proglide, we remove the wire as soon as the marker is at the edge of the skin, and we introduce the device up to, we are in the arterial lumen, so we see the bleeding. We lift the number 1. It's really important to keep 45 degrees angulation exactly in order to be able to have the pedal of the prostyle parallel to the arterial wall and to puncture perfectly the artery. The first proglide is deployed with the device slightly clocked towards 11 o'clock, so towards the operator, as you have seen. Remember that Navitor is a really small profile. This is a 27 valve, so it's compatible with a 15 French outer diameter sheath. You have seen the introduction of the wire where the marker tells us to put it. So it's a small caliber, small profile device if compared to other TAVI device, but still 15 French needs a proper pre-closing with 2 devices with this angulation that I just mentioned you. So this is the second device. The second device will be deployed again with this 45 degrees angle as compared to the, let's say, patient, or as compared to the floor. But it will be slightly clocked clockwise, so far from the operator, at slightly 1 o'clock. Dan weer zijn, is slecht. So 1 o'clock.
45 degree again.
This is the puncture. Typically, you don't have this recoiling of the needle like you have sometimes with the proglide, because the needle material and structure have been improved. And now, since this patient has a really straight vessel, we carefully introduce directly the stiff wire directly in the prostyle in order to put then the 14 French sheath that we are going to use for the predilatation.
Excellent, Mauricio. Very nice display of ultrasound-guided percutaneous access. Nicholas, 2 questions for you. I know you use ultrasound as well for your punctures. Do you use a micropuncture kit as well, or do you go directly with a Cook needle? That's one question. And the second question is, at what point do you give the heparin when you're doing a TAVI?
Yeah, good questions. And so the short answer is we don't use the micropuncture needles. That is, I think, the added value of ultrasound guidance. If you really know how to use ultrasound, then you see your needle, your Cook needle enter the vessel, and in principle you know that you've entered the vessel because you've seen it, and you see then the pulsatile flow, and you have avoided the calcium. So I don't see the added value of micropunctures with ultrasound guidance, to be honest. And then when do I give heparin? I give heparin if I have obtained all my accesses. So I do the radial access and then the 2 femorals, and then I give the heparin.
Okay. Mauricio clearly advances the stiff guide wire through the perclose. We do a similar thing purely to reduce time, but in many centers they'll place a 9 French sheath, for example. Is that something that you do in Rotterdam, Nicholas, or what's your practice? Do you upsize first?
No, so we don't upsize anymore either. So either we do the measurement with the Manta measurement tool if we use Manta, or we just insert a regular longer wire or a 80 centimeter stiff Cook wire. Those are the 2 options in my side. And if it's not a challenging anatomy, then a simple 035 or 038 wire might be enough to accommodate your large bore sheath.
Okay, Mauricio, so good, safe vascular access is achieved. Take us through the steps of deploying the Navitor system.
Yeah, let's move to the valve implantation.
Our standard setup, if there are no electrocardiographic abnormalities, is to pace over the wire during the procedure in order to spare one access. And in this case, you are going to pace over a press-shaped wire. As you may see, there are stents in the coronary, so the patient has coronary artery disease. So one of the reasons to choose Navitor valve is that you can do commissural alignment, and if you cannot do it because you don't see well or because there is a lot of tortuosity, you have anyway an intra-annular valve that allows easy access to the coronary together with the large dimension of the stent cell frame. Here you can see the hemodynamic trace showing the severe stenosis. So this is the overlapping cusp view where we overlap the right and the left coronary cusp on the right part of the screen. We are going to perform an injection. We will use this view for our starting position because here we are coaxial to the LVOT, so we know exactly how deep we are in the LVOT, and we also know that we have 1 commissure on one side and 2 commissure on the other side, so we can even check commissural alignment. I think now we are ready for the balloon predilatation. We are going to use a 22 millimeter balloon. The nominal diameter of the valve is 23, is quite round. Pacing on. Stop pacing. Now we are ready. Maybe I quickly show the FlexNav system. This is a 27 Navitor valve crimped inside the FlexNav. And now we will introduce sheathless, the FlexNav system. And I will orient by turning the handle 90 degrees clockwise. So we don't introduce like this, we slightly turn like this in order to have the flash port looking below, so at 6 o'clock. The configuration that gives the higher chance of commissural alignment. It's really important during the deployment to go extremely slow to give the nitinol the time to warm up. The first strat could be done also a bit faster because the stent of the valve is still fully sheathed. And now the first 2-3 millimeters of the stent are outside. Since the patient is really stable, we just wait a few seconds to give the nitinol the time to warm up a bit. And I move forward with a slow deployment. We try to stay only a few millimeters below the annulus. Our reference again is the pigtail, and we are looking at the stent of the valve. And then I continue going really slow. We have no parallax, so we like this projection. Okay, now I go on really slowly up to the stop. And then we will check in LEO our contact on the left. And just pull back the wire a bit. So now I slightly pull back the Safari wire to centralize the nose cone, and we remove the system by keeping the wire in. We recapture the nose cone in the descending aorta. There is no gradient. The end diastolic pressure is really low with a really favorable aortic regurgitation index, so hemodynamic is good. Let's check, before doing an angiogram, let's check the commissural alignment. So I come back to the overlapping cusp view. I think it's correct. It's good. So now in this view, which is the overlapping cusp, we have one commissure on the right and two commissure on the left. So if you are perfectly or good aligned, we will have one commissural spot on the right, isolated, and two on the left. And this is actually what we see here. Wow. So everybody, it was not prepared, this wow, everybody say wow, because there is really no leak. And I injected almost 20 cc, so it's a proper injection.
Okay, I think you have seen the valve implantation. The steps are the same that Nicola showed us. We do as Darren is doing. So we start in areocaudal overlapping cusp and then they switch to the left. But I think it's just important and mandatory to check in two projections, the high and the expansion of the valve.
Yeah, I think
there are quite some questions on the pacing. So if you would rely on pacing during the deployment, Darren, what would be your typical frequency? Is it 120, 130, or is that also 180 while you are deploying?
Yeah, so I think it depends. I think with the Navitor system, you deploy a little bit more slowly. So a very high pacing rate, which really impacts the patient's hemodynamics, will not be tolerated. On the other hand, the technique with Evolut, for example, now is to pace fast and to deploy the mid portion of the valve quite fast. So I think it depends on the patient and the system you're using. With something with Navitor, for example, I think it's very reasonable to pace, for example, at 120, try and get the systolic blood pressure to 100, depending on how much aortic incompetence you have, how much movement you have in the valve, and to try and have a nice slow procedure. And that would be our practice.
Do you also use pacing at the final step of the deployment? So you reach that point of no return, you press the button. If you then continue, you still use pacing?
Yeah, we do, and we do the same thing for Evolut too. We like to pace as we're releasing to try and reduce the impact of any stored tension in the system or any manipulation that you've done to try and get a good implant height, and therefore to try and leave the valve in its current position. We know that with these bottom-up systems, these long stent frames, that they can move on deployment. It seems to be a lot less common with Navitor because it's a softer valve, a softer delivery system, but we still do it.
Yeah. Good.
Mauricio, we need to move forward, so maybe you might tell us how did you close the access in this particular patient?
Yes, exactly. I don't think there is a reason to see it. We just closed with the two pre-implanted prostyle, and we put a 8 French angioseal. As you do, we tend to do it as a standard in order to safely mobilize early the patient, and if possible also to get him discharged quite early. And okay. There were no vascular complications in this case.
I noticed that both of you use an 8 French angioseal in the two cases. We would think about how much bleeding have we got, what is the size of the femoral artery, and if it's a small patient, small femorals, no problem using a 6 French. And Nico, I very much like your technique of put the dilator for the angioseal in. If you have no bleeding, you know that you're going to be fine once you deploy. If, on the other hand, you have a lot of bleeding, then maybe you need to think about, for example, a different closure device. Mm-hmm. Nicholas, sorry, go ahead.
Yeah, that was a question from the audience. When you use that technique, when do you decide that you really close the sutures? Is it before you put in the angioseal sheath or after? I typically do it on the wire, I must admit. So I close one suture, then I assess, and if there is clear profuse bleeding, then I will not use the other perclose. Then I go in with my sheet, and if that has solved the problem, then I will close the second suture and then deliver my plug. That's basically my approach. But I think there are several variations to that theme, I assume.
Yeah, I like to close the suture on the angioceal. So we, for example, if we put 2 percloses in, we would pull both of those, tampen both of those down on the artery. If we still had bleeding, then go ahead and put the angioceal on, deploy the angioceal, and finally then bring the perclose sutures right down on top of that again. The one variation that we use is that if we're using a single perclose and an angioceal, I will again pull the first perclose, insert the angioceal, deploy the angioceal, and then finish with the deployment of the perclose again, right down onto the plug of the angioceal. But I think there are different ways of doing it.
Yeah.
Nico, any final questions from the audience that we haven't addressed before we go?
Well, there is one permanent question on the hypertrophic ventricle, and I think that is interesting because that makes it very particular. So what is your approach when you do have this very hypertrophic ventricles in terms of your fluid management? I think, again, I refer to what I said earlier. I think the invasive hemodynamics before and after the valve implant are essential. And if you really have very low left ventricular end diastolic pressure, so below 5, then it's time to start adding fluid to the patient. I don't think it is needed to have central venous pressure monitoring. As a matter of fact, all our patients, they remain in a holding area for 4 hours, so they don't go to an ICU or CCU. And if they are completely stable, then they will go back to the ward. So central venous pressure monitoring is really rare in TAVI patients these days. Darren and Maurizio, what is your take on that?
So yeah, I would agree. We don't use CVP monitoring. The severe LVH, I think there are 2 issues. First is it affects the choice of wire, and we would go for a smaller wire and a smaller ventricle. I think that just makes sense. And then I think that the hemodynamic impact of that wire in the ventricle is felt more significantly in those small ventricles. And so if we knew up front that the patient had severe LVH, which we should from our CT scan, the minute that patient comes in and is in our day ward getting checked in, we would start IV fluids. And the idea would be to plump up that ventricle to try and have less hemodynamic impact of any wire in that ventricle. Because sometimes you put the wire in, the patient has lots of PVCs or they get hemodynamic collapse. And we think that maybe giving some fluids early while the patient's in hospital helps, but I don't know that I have any evidence for that. Maurizio, what do you guys do?
Basically, we have the same approach as you. I think it's really important for the selection of the wire. We use almost always an extra small, but it's depending on CT and on hypertrophy. And then we have the same approach for fluid monitoring. I would say for fluid management, we don't use PVC monitoring, but we rely mainly on, hypertrophy detected at echo and CT and how the ventricle behave after the insertion of the wire.
Okay, Nicholas, over to you to close. We're a few minutes behind, so over to you, our chair, to close the session.
I think this was an exciting webinar. What we learned and shared are different techniques of safe exercise management, large bore exercise management. At the same time, we also illustrated the use of, in this case, Navitor, the Navitor platform, to treat patients with challenging, heavily calcified anatomies in hypertrophic ventricles. And I think what we also nicely demonstrated is how the Navitor platform has improved. It has become a very nice valve design with a good profile, also has sealing features that make it suitable for use in lower risk patients with also longer life expectancies. And I think we also addressed lifetime management. We are also very cognizant of coronary and commissural alignment and coronary access, because we are treating younger patients with also longer lifetime expectancy. With that, I would like to thank Darren and Maurizio for a very fun interaction. I really enjoyed it. I think it was educational, but it was also among colleagues, and I really had a great time. I hope the audience also enjoyed the quality and the way we did this webinar. Thank you very much for attending. See you next time. Have a good evening.
Bye, everybody.
Thank you, everybody. Bye-bye.